Assalamu alaikum. Good afternoon. Thanks for all organizers, moderators, and sponsors of Kasr Al-Ainy Orthopaedic Review course. Welcome, everybody. Our topic is spinal canal stenosis. These are our intended learning objectives: definition, anatomy, classification, clinical picture, investigations, and differential diagnosis, treatment, and a talk on special forms of spinal canal stenosis. Spinal canal stenosis is an abnormal narrowing of the osteoligamentous vertebral canal and or the intervertebral foramina, causing direct compression of the dural sac or caudal nerve root or their vasculature, producing radiculopathy or claudication. Epidemiology of lumbar spinal stenosis. It is seen in 20 to 25% of patients aged above 65 years old, slightly more common in males, and about 90% occurs at L4-5. It's more common in Caucasian race, patients with increased body mass index, and patients with congenital spinal anomalies with failure of posterior elements to develop, leading to short pedicles and laminae. The anatomy of a spinal canal, it includes the central canal and the lateral canal. The lateral canal was subdivided by Lee into three zones. The entrance zone, or also called lateral recess or the subarticular zone, the foraminal zone, which between the medial and lateral wall of the pedicle, and the exit zone, or the extraforaminal or the far lateral zone. These are structures which can compromise the canal and the foramen. Bony structures including facet osteophytes, posterior vertebral body osteophyte, spondylolisthesis, while soft tissue include bulging disc, ligamentum flavum, and synovial facet cysts. Pathophysiology of narrowing starts by disc degeneration with reduction of disc height and loss of the ability of disc to act as shock absorbing function, with transfer of the stress to the facets, leading to facet overload with facet hypertrophy and osteophyte formation, ligamentum flavum buckling and hypertrophy, with subsequent narrowing of the canal and the foramen. Pathophysiology of claudication and pain. Narrowing of the canal and the neuroforamina cause decrease in blood flow and nutritional supply. Block at two levels leads to venous congestion in the uncompressed segment. With the arterioles continue to feed the segment, there is reduced blood flow, oxygen supply, and nutrition, building up of metabolites in the uncompressed segment. So either a two-level central stenosis or a central stenosis with root canal stenosis must be present for neurogenic claudication. Arnold et al. In 1976 classified spinal canal stenosis into congenital and acquired, with the congenital subdivided into idiopathic and achondroplastic. It's not only the anteroposterior diameter, but also the shape of the canal. So in the congenital stenosis secondary to trefoil shape, the canal, there is narrowing of the anteroposterior diameter and also lateral recess stenosis. A study based on axial MRI identified three patterns of congenital stenosis. The first one with decreased anteroposterior canal diameter with flattened appearance and short pedicles, decreased interlaminar angle, and global decrease in the canal, narrow anteroposterior and transverse diameters, and decreased interlaminar angles. Acquired stenosis includes degenerative, which is the most common type, combined like degenerative on top of congenital, spondylolisthesis, and the spondylolytic, iatrogenic, post-traumatic, miscellaneous, like in Paget's disease, acromegaly, fluorosis, dish, and ankylosing spondylitis. Anatomical classification includes central canal stenosis caused by disc osteophyte complex and ligamentum flavum with non-specific root compression and symptoms of the lower nerve root, the traversing root. Lateral recess stenosis, which is this part medial to the pedicle, caused by facet hypertrophy and a huge osteophyte, which also affects the descending or the traversing nerve root. So L4-5 affects root 5. This is the shape after proper decompression. Foraminal stenosis between the medial and lateral border of the foramen, caused by reduction in disc height, foraminal disc prolapse, facet osteophytes, and angulation like the degenerative scoliosis with narrowing on the concave side. In this side, it affects the exiting nerve root. So at L4-5, the L4 root is affected. Also in the extraforaminal stenosis, lateral to the lateral edge of the pedicle, caused by far lateral disc herniation, also affects the exiting nerve root. L4-5 affects root 4. Natural history. In most cases, symptoms develop gradually. Sometimes it occurs in acute form like following trauma or physical activity. There is no close association between the anteroposterior diameter of the canal and the clinical symptoms. In one study, non-surgical treatment group, symptoms worsened over time, but at 4 years, 50% of patients had good results, while 80% of surgically treated patients had good results. One study showed that 70% in moderate untreated stenosis remained the same, 15% deteriorated, and 15% improved. Long-term follow-up of 10 years, there was no difference in the conservative and surgical group regarding back pain, but with significantly improved patients regarding radicular pain in the surgically treated group. Clinical picture, mostly patients with the stenosis present with back pain and sciatica, sensory disturbance in legs in 70%, motor weakness in 1/3 of cases, and voiding disturbance by bladder affection in only 12%. Very famous, very well known that there is improvement of symptoms with trunk flexion, sitting and stooping due to stretching in the posterior annulus and also ligamentum flavum with subsequent widening of the canal. But in long-standing cases, more advanced, sitting or lying down are less helpful to relieve the pain. Distribution of pain in the lower extremities is dependent on the area of stenosis. So with central stenosis, symptoms develop in both buttocks and both posterior thighs in non-dermatomal distribution, while in lateral recess stenosis, symptoms are usually found in dermatomal distribution. Also, lateral recess stenosis may have more pain during rest and at night, and they have more walking tolerance than central stenosis. In severe cases, rest pain or a neurogenic bladder can develop, so always ask about changes in bowel and bladder, including urgency, frequency, and loss of control. If any of these complaints are present, full urologic workup is indicated. Remember that there is recurrent urinary tract infection in up to 10% due to autonomic sphincter dysfunction. In general, physical examination in spinal stenosis is inconsistent. Stretch tests are usually normal. Neurological examination is usually normal, but some abnormality may be detected when the patient is allowed to walk to the limit of pain. Peripheral pulses should be examined. Special tests. Stoop test. Ask the patient to walk till pain develops, then continue to walk. Patient would assume a stooped posture. Symptom will disappear. Lumbar extension test. So extend the patient lumbar spine for 30 to 60 seconds. A positive test is reproduction of buttock or leg pain. Kemp sign is unilateral radicular pain from foraminal stenosis made worse by back extension. Valsalva test does not worsen the radicular pain as in the case of herniated disc. Investigations include plain radiographs with non-specific degenerative findings, osteophytes, disc space narrowing, others like degenerative scoliosis, spondylolisthesis, and dynamic views for instability, with translation of 4 to 5 millimeter or rotation of 10 to 15 degrees between flexion and extension, suggestive of instability. Here you can see clearly the significant reduction in length of the pedicle, suggestive of congenital stenosis. MRI in patients older than 60 years of age, 57% would have abnormal MRI. MRI should be matched with symptoms of patients. Patients with severe radiographic stenosis, only 17% would have symptoms. He described the classification using MRI for degree of central canal stenosis. T2 sagittal images are helpful for diagnosing central canal stenosis. So this is the mid-sagittal T2 MRI. These are the spinous process cut. You can see central canal stenosis. In sagittal T1 weighted images, these are most helpful to diagnose foraminal stenosis by reduction of perineural fat. You can compare this one with this level. Extraforaminal stenosis are best visualized on the axial T1 images by obliteration of the nerve normal interval of fat between the disc and the nerve root. So this is the normal side. Here the fat is obliterated by an extraforaminal disc. Some studies were performed to diagnose lateral recess like this one by measuring lateral recess height, lateral recess depth, and lateral recess angle, which is more or less of an academic interest. Computed tomography by making water-soluble myelography followed by CT is very helpful in some situations like dynamic stenosis, failed back or recurrent stenosis, severe scoliosis, metallic implants, or other contraindications to MRI. You can see the interruption of dye in this cut. This is the famous claudication. You can have a close look on it and read it many times just to revise. It contains lots of detail, but most of it are well known to us, like the cramping pain with walking and standing, but only with walking in case of vascular claudication, bicycle test, walking uphill, presence of back pain, examination of the pulse. Just spend some time and have a look on it. Herniated discs are still confused with spinal canal stenosis to some doctors. Remember, herniated disc usually occur in younger patients, usually unilateral, with neurological findings are common. Central disc herniation may mimic the pain of classic spinal stenosis. However, it's more abrupt in onset, increased pain while sitting, associated neurological findings, and positive sciatic stretch test. Peripheral neuropathy. By the distribution and through nerve conduction studies, you can diagnose, you can identify the difference between them. Hip-spine syndrome. Coexisting hip and spine pathology must be determined to identify the primary pain generator prior to surgical interference, like using diagnostic injections. Treatment should depend on the severity of clinical symptom, the type of stenosis, like lateral recess, foraminal or central, or pathological or others, extent of stenosis, single level or multiple levels, and associated instability or deformity. Delayed surgical intervention does not deny the benefit of surgery. Non-operative is the first line of treatment. Conservative treatment includes activity modification, the mainstay. Conservative measures like some rest during flare-up of symptoms, not exceeding 2 days, pain management, and exercise program. Traction is not proven to be helpful in lumbar spine. Exercise includes strong stabilization, primary flexion exercise, stationary bicycle riding, aquatic exercises, partially loaded treadmill, aerobic fitness, and others. Pain medications including paracetamol and non-steroidal with taking care of gastrointestinal affection and renal impairment. Antidepressants in low doses are occasionally helpful as an adjuvant to the pain medication, especially in neuropathic pain. Gabapentin resulted in increase in the walking distance, decrease in the VAS score for back and leg pain, improvement in sensory deficit when compared to the standard treatment. Calcitonin and bisphosphonates have been established to patients with Paget's disease with spinal canal stenosis. Epidural steroid used very frequently with some controversy. The ideal candidate is patient with acute radicular symptoms or neurogenic claudication, unresponsive to traditional medication with significant impairment in daily activity. It depends on the idea that it's a strong anti-inflammatory action to reduce the inflammatory response and edema in neural elements. Several studies showed that injection produced short-term relief of symptoms in approximately 50 to 80% or 90% of cases. Operative treatment includes wide pedicle to pedicle decompression in persistent pain 3 to 6 months with failure of conservative measures or progressive neurological deficit. Decompression plus added instrumented fusion in case of segmental instability, degenerative scoliosis or synovial facet cyst, surgical instability created by complete laminectomy, foraminal stenosis, adjacent segment degeneration, and recurrent cases. Take care, do not injure the pars interarticularis. Preserve at least 50% of each facet if no fusion is planned. Try to localize the source of pain preoperatively by selective blocks to allow a more focal decompression. A good approach is to start with the point of less severity. This often frees the neural structures enough to make the final decompression simpler with less risk of damage. Better to use minimally invasive techniques with better preservation of soft tissue, microscope or magnifying loops for better visualization, and different surgical techniques. Risk of adjacent segment degeneration is more than 30% after 10 years with fusion. This is the standard pedicle to pedicle decompression. Starts with the interspinous space by cutting the lower half of the proximal level, then remove the part of the cephalad lamina till the insertion of ligamentum flavum. Do not forget to preserve the pars, then exiting nerve root decompression, then descending nerve root decompression, finally lateral recess decompression, and make sure that there is no associated disc herniation. Can be done through laminectomy or interspinous approach or through laminotomy approach. Don't forget helpful techniques like over-the-top techniques. Through a single unilateral laminotomy, you can go to the other side by undercutting the base of the spinous process and the contralateral lamina through tilting the other table, and you can do bilateral decompression from the same side. Here the nerve root is completely decompressed and also going to the contralateral side. Minimally invasive tubular retractor and dilator system gives us the full job through small incision around 2 cm. Also, you can do contralateral decompression by tilting the table. Distraction laminoplasty. So you preserve most of the lamina, all the lamina, and do the full job of decompression, which gives you large bed for fusion. There are special indications for fusion. As we mentioned, in this case, there is significant narrowing. You can hardly do proper decompression without sacrificing the facets. And here also you can see significant foraminal stenosis. So possibly you will need to sacrifice the facets for fusion. Different modalities of fusion, posterolateral fusion, PLIF and TLIF, open and minimally invasive, and sometimes long segment like cases of degenerative scoliosis. Special forms of spinal stenosis. Thoracic stenosis. It's a rare entity caused by ossification of ligamentum flavum, OLF, in 40% of cases, OPLL in 18%, combined cases 7%, thoracic disc herniation in 32%. Usually there is ossification in thoracic disc. Should be stressed that non-surgical treatment is usually not effective in thoracic stenosis, and surgery is the only effective treatment. In patients with the chest or abdominal wall radiculopathy or mild myelopathy, short-term conservative treatment may be helpful with close follow-up. Indications for surgery include serious symptoms and sudden progression. Approach is planned according to the extent and the site of pathology. This is one interesting case in Kasr Al-Ainy. We did this patient around 3 weeks back. You can see the significant ossification of ligamentum flavum with significant narrowing of the foramina. This is the axial CT cuts All this extra calcification is abnormal. This is the usual dimension of the canal. You can compare this canal with this one and this one. This is the MRI. All these are ossified ligamentum flavum, 3 levels. This is the normal canal. This is the narrowed canal. And this is the post-operative after wide laminectomy decompression and fusion. One more form is the tandem spinal stenosis. Refers to compromised canal diameter in at least 2 distinct regions of the spine. Occurs in 7.6 up to 60% of spinal stenosis according to literature. Historically was described on cervical plus lumbar stenosis. Daggy et al. Defined it as the clinical triad of intermittent lower extremity claudication, gait disturbance, and upper lower motor neuron signs. Lee found that 27% of patients with symptomatic lumbar stenosis has associated asymptomatic radiographic cervical cord compression. Risk factors for tandem stenosis includes age of 70 years, male sex, multi-level symptomatic lumbar stenosis. Lee concluded that isolated congenital stenosis increases the likelihood of multiple stenotic spinal segments. C. et al. Concluded that surgeons should maintain high index of suspicion for tandem stenosis in OPLL. Sometimes upper motor neuron lesion symptoms may be blunted or completely masked by the presence of lumbar stenosis, and similarly, upper motor neuron symptoms may be dominant despite history suggestive of lumbar stenosis. If history and examination are coinciding with upper motor neuron affection and upper extremity signs and symptoms, then further cervical imaging in the form of radiographs and MRI should be performed. The presence of OPLL warrants MRI of both cervical and lumbar spine. Careful attention should be paid to deficit in cervical range of motion and the presence of provocative maneuvers like l'ermite and Sperling, warranting further cervical investigation. If the surgeon detects clinical myelopathy, but imaging does not support the diagnosis of cervical stenosis, thoracic spine should be imaged. These are some clinical scenarios which raise the suspicion of tandem stenosis. History and examination consistent with cervical spondylotic myelopathy, but the absence of upper motor neuron signs in the lower extremity, which suggestive of concomitant lumbar stenosis. History consistent with neurogenic claudication, but the presence of imbalance, bowel and bladder dysfunction, compromise of fine motor tasks, raise the suspicion of proximal stenosis, cervical or thoracic. History consistent with cervical or lumbar stenosis, but symptoms are disproportionate, suspect non-contiguous stenosis as a possible explanation. If you have loss of balance, loss of fine motor or manual dexterity, bladder and bowel dysfunction with upper motor neuron signs, always suspect affection of the cord and conus. If you have spinal claudication, lumbar radiculopathy, lower motor neuron signs, this is suggestive of coda equina affection. Decompression of a single region, staged decompression, and simultaneous decompressions all have been described with no general consensus. Most authors found improvement in lower extremity symptoms in all patients who underwent a primary cervical decompression, although extremely rare complications in which surgical positioning and intervention resulted in neurological deficit and paralysis as a consequence of unrecognized tandem stenosis, like sometimes coda equina occurred following ACDF or quadriparesis following lumbar decompression. Universal precautions. Cervical spine should always be addressed primarily. Avoidance of neck hyperflexion and hyperextension. Minimization of long-acting muscle relaxants that impair the natural muscular protective mechanisms. Neuromonitoring modalities in severe tandem stenosis. Avoiding undue lumbar flexion or extension during positioning. A minimum of 3 months follow-up after cervical decompression to allow for improvement of residual lower extremity symptoms before proceeding to lumbar decompression. The take-home message: understand different types of spinal canal stenosis according to anatomy or etiology. Proper understanding of anatomy and relevant radiology together with clinical picture helps proper decision making and improving outcome. Different imaging and neurophysiological studies helps to identify cause and site of pathology. Needless to mention the importance of excluding other similar conditions to achieve successful outcome, the differential diagnosis. Conservative treatment has a great role in the treatment plan. Surgical plan is set case by case. Remember the rare thoracic stenosis. Remember the more common tandem stenosis. Thank you.